Welcome to the Transforming Trauma podcast. Transforming Trauma is presented by the NARM Training Institute. I'm your host, Emily Ruth, and I'm so glad you've joined us today. Hi, Transforming Trauma listeners. We're excited to share with you that we have 2 upcoming Level 2 NARM therapist trainings beginning in May and in June. If you're a licensed mental health practitioner, we invite you to join us for either of these NARM therapist trainings. One training will take place in Austin, Texas, and the other training will take place live and online. This Level 2 training is designed to support mental health professionals who work with clients or populations dealing with complex trauma. Being trained in NARM, one of the first clinical models specifically designed to address ACEs and CPTSD, supports therapists to learn how to address the long-term impacts of adverse childhood experiences and complex post-traumatic stress disorder. If you're interested in this training, we encourage you to register now to reserve your spot. For more information about both upcoming trainings, please visit narmtraining.com/level 2. We look forward to you joining our growing international NARM community and are inspired to work with you to bring NARM to your clients and communities in order to transform trauma. Today's interview is with Dr. Carrie Griffin, a board-certified osteopathic family medicine physician and addiction medicine specialist. She is fellowship-trained in maternal, child, and reproductive health, and since 2016, she has practiced obstetrics and addiction medicine. Her experiences with birth and substance use disorder in pregnancy led her to seek further education and training in trauma. Her clinical interests are the intersection between body, mind, and soul, and the infinite ways that transformation can occur. Her work centers on activating and witnessing the innate capacity for healing inherent in all beings, and choosing the modalities best befitting the individual before her. I invite you to enjoy this episode with Dr. Carrie Griffin. Today we have Dr. Carrie Griffin joining us on the podcast. Dr. Carrie, welcome to Transforming Trauma.
Thank you, Emily. It is such a pleasure to be here.
Yeah, it's a pleasure to have you. So if it's okay, we'll just dive right in. I always start these conversations by just asking, what is it that you would like for our listeners to get from our conversation today?
I think what I would love for listeners to glean is that there's a place for NARM outside of just a routine one-to-one therapeutic relationship. And just starting to plant seeds of imagining how a NARM clinical approach can be planted in other settings. I will, of course, be talking about a medical setting, but I think expanding the horizons of where NARM can go.
Oh, I love that. I get chills just like thinking about all the ways that NARM can show up in the world around us. So thank you for bringing that. I'm excited to have this conversation.
Yeah.
So I would love if you could tell us a little bit more about the work that you do and then how you witness and work with those who have experienced complex trauma.
Sure. So I have had a pretty eclectic career. I'm a family medicine physician. That's what I was first boarded in. I did a 2-year fellowship in maternal, child, and reproductive health. So what that means is that actually for the last 7 years, all I've done is birth work. So really I practice maternal child health. And then in addition to that, I'm actually boarded in addiction medicine. And so the intersection between those things means perinatal substance use really became my clinical passion. From the beginning of intern year, that was really a part of medicine that just spoke to all levels of my own being. And I think I've spent a lot of time understanding what it was about that particular nexus of interests in that population that really called to me. And speaking to a group of trauma therapists, I think it's pretty easy to understand how one goes from being really interested in substance use disorder in pregnancy and how do I best take care of this dyad to wanting to study to deepen and understand how to treat complex trauma. So that's kind of the big arc. And currently I practice in rural Northern California. I part-time deliver babies and provide prenatal care and women's health care in a variety of settings. I work in 2 native health clinics and as well at a federally qualified health center. I still take call once a week and then 1 weekend a month. So 7 days a month still in the birth world in the hospital. Mm-hmm. And then I also have a private practice because it is really hard to practice in a way that I think feels aligned for me in a routine medical setting. So in my private practice, I actually found NARM through becoming a somatic experiencing practitioner. So I practice SE and NARM and also work with ketamine in that space. So use ketamine-assisted psychotherapy as well. And I would say that that space is a place I'm growing. I opened that practice in August of 2020. And I think increasingly what I would call it is integrative trauma treatment. So that may mean we're using pharmaceuticals, maybe we're using herbs. My background before medicine was teaching yoga, and I became a yoga therapist before I went to medical school, so had studied some Ayurveda and just continued that more integrative path longitudinally throughout training. So for some people, that feels more aligned. And certainly some element of psychotherapeutic skill is underneath all of that. So NARM in particular has really kind of become the bedrock of how I practice. And what's been so interesting, because I'm still, I just finished the level 2 training last year. I started level 3 this year with this cohort. And what I find is that you can actually take these pillars, and even if it's not the same, the depth is very different. They apply to a medical visit in a very similar way.
Okay, now I'm really excited because there's a lot of layers there. You're in a community setting, and then you have your private practice, and there's these different ways that you're showing up in those spaces.
Right.
Maybe they're more similar than I'm thinking, but what is it that's different?
I think what's partially different is in my own office, it's entirely my own space. So people are scheduled for an hour. We're really able to start with, what do you want for yourself today, right? We begin with contracting from the very beginning. And it may be a visit for maybe someone seeing me more for their recurrent bacterial vaginosis or something like that. Maybe it is more of a medical concern, or maybe they're there because they've learned about NARM and they're like, I've seen a lot of therapists, I've done a lot of work, I have a high amount of childhood trauma, and I'm really here to transform that. In which case, of course, we're starting with pillar 1 and unveiling what is it you want for yourself and searching for the state that it is that they really want to be immersed in. But that principle of what do you want for yourself can still happen at the beginning of a visit. Now, in a community setting, in the hospital, if you're in labor and you're 8 centimeters, you probably want to have a baby, right? Like your contract is probably pretty straightforward, but there's layers to that, right? How do you want to have this baby? Who do you want in the room with you? Do you want baby placed right on your chest, which is pretty routine nowadays? Do you want delayed cord clamping? I mean, I think that there's all the aspects of consent, right? That pillar 1 is really rooted in, is reigniting the adult consciousness around what do you actually want? What do you say yes and no to? I think there's a huge movement in medicine towards shared decision-making, towards consent, that pillar 1 really can be applied in that setting. In an office visit, you can still do that. But I will say one of the things that I think NARM, more than any of the things that I've really studied, helped me understand is what my contract is in the 20-minute medical visit that people are scheduled for. And I think in my own being, I had a lot of confusion. I wanted to do deeper work with people, but medicine doesn't honestly give you the skill set for that, at least not naturally. And what I realized, particularly when you get into module 3 of the level 2 training, and it's all about let's dig into countertransference, what I realized is I was showing up to that space with kind of a loaded contract myself, when really in that moment, the patient needs a certain level of physical safety and medical care that they've clarified is okay. So if you are 28 weeks pregnant, you're there, and we are there to talk about, have you been screened for gestational diabetes? Have you been screened for anemia based on new guidelines? Have you had a recurrent syphilis screen? And what do you want for yourself, right? So I've got my piece of like, what's evidence-based care that we need to discuss at this visit, but you can invite in the patient's sense of, what is it you want for yourself? Oh, you've been sitting here wondering, what does it mean to have an epidural? And will I become paralyzed if there's a needle in my back? Great, we can talk about that. So I think it's realizing that I think I was doing a lot of trying to dig into everyone's childhood trauma in the 20-minute office space and realize that that's not an appropriate setting for that unless it comes up, right? Sometimes it just bubbles up to the surface and that's what's there. And if that's the case, then having a greater understanding of what complex trauma is, what it looks like, where patients are bringing in their survival strategies. I find that I will frequently reflect back to people all the time how a behavior that may be serving them. Substance use is a great example, right? Instead of reframing substance use as a way that you're harming yourself or in a perinatal setting, harming your newborn, it's reframed as this is something you're doing to survive, right? The suffering is so big that this is something that you are doing because it's the only way to imagine making it to the next moment.
I love this. I find that for so many of us, it can feel like a jump to like wrap our heads around the idea of someone utilizing a substance to survive, as opposed to like, but you're expecting a baby, you're growing a life. Like what's happening there, to get that curiosity of how is this helping you survive?
Right. Right. What is it offering you? Because it's offering something.
Something.
Right?
Mm-hmm.
Like something is being fed there. I often use the archetype of the hungry ghost from like Tibetan psychology. And people really resonate with that. This idea that like there's something in me that just endlessly needs. Right. And you think about that attunement survival style, right? That subtype that feels like it will never be enough. Right.
Yeah.
I remember learning about that and feeling like it. I have a meditation practice that relates to these, 6 different Tibetan Buddhist kind of psychological archetypes. And certainly that piece of like, I just need more, trying to heal that brokenheartedness that's really at the heart of attachment trauma.
Well, I love what you've shared around that. That's a really, like, in a very short time, you've shared with us really kind of a good bird's eye view of like how you're using this and how you're working with those who have experienced complex trauma. So I'm curious how you would define complex trauma. Like, what's the definition for you?
So for me, when I'm talking to patients or when I'm teaching, I define complex trauma as pervasive relational difficulty over the course of adulthood. I invoke the adverse childhood events screening, the ACEs screening. But complex trauma to me means that there's been a series of ruptures, particularly in relationship or attachment. And that can take the form of physical violence, emotional violence, chronic misattunement. And what that yields is a lack of a person being able to identify their own needs. And really, I realized what I was about to transition into saying is really like the 5 domains, right? Can they connect? Can they attune? Can they exercise their own will? Is it safe to trust? Is it safe to love? I mean, I think that I've really internalized those kind of 5 areas of being human and what it means to relate as a way of assessing what trauma looks like. Where is it functioning in someone's life? Where is it active? Where is it a little more quiescent?
Yeah. I love what you're sharing here because, and I've talked about this on this podcast before, my own experience a little bit about what brought me to this work. And really, for me, a huge piece of it was my own pregnancy and labor and birth experience because of what came up for me while I was pregnant. So many things that I'm so curious for others how they experience that. But things that came up for me, it really felt like such a creative time. Like not only was I creating a life, but like it was an opportunity for me to create a new way of showing up,
Yes. This is what I love about pregnancy and the perinatal period is that it is, in some ways, it is a natural moment in life where you reflect, right? Yeah. You're in the present, but you're reflecting backwards about your history. I mean, it's interesting to me that in so many trauma trainings now, we're talking about intergenerational trauma, almost like it's a new idea. People know it. It's in their bodies. It's in their bones. They get pregnant. I mean, a patient yesterday telling me, I thought I had done all this work. I waited till my 40s to get pregnant because I thought I had purged all of my mother's anger, all of the violence that happened to me. But now I have toddlers and it's all still here. Here it is again. And we know this. Women know this in their bodies, in their beings. And I just continue to be in awe of what pregnancy and parenting offer in terms of portals for transformation, and particularly for complex trauma. And it's interesting, the way I just defined complex trauma was so focused on ruptures in caregiving relationships. Where else, right? If we heal trauma in relationship, where else is that going to happen? But as we learn to parent, not just our own inner little people, but our own maybe physical little people that we've created.
Yeah, I love that. Now I'm getting curious, what brought you to this work and what led you to NARM?
So I already shared that I really had fallen in love with perinatal substance use clinically. And what I started noticing in patients, actually there was one really particular birth. I was in fellowship at the University of New Mexico, and a patient had really wanted me present at her birth. I was there, and it was her second baby, and she was pushing. And I watched her dissociate. I just watched her completely leave. She looked at me and I said her name, and the baby's heart rate was doing some decels and other things. Like I really needed her to push this baby out. And I looked at her and I was like, come on, like you can do this, like do this now. And she looking me dead-eyed, pushed the baby, and the baby was pretty high in the pelvis, but pushed the baby out in one push. And I knew something had happened like in this moment for her, and I didn't know what it was. Deliver the baby, do all the things. The next day when I'm rounding, she shares with me that she had had a flashback of her father who had sexually abused her. And so she dissociated, and she's like, but when I looked at you, I knew I was going to be strong enough to stop this, that this was my moment where I could change this. And it was really profound. She'd had postpartum depression with her first pregnancy. She didn't with this one. She returned to work at a new job that actually really worked well and supported her and her family, which I'm sure you know is incredibly hard to do as a working mother in late stage capitalist America. And it's like I watched her just go through this unbelievable transformation from this moment that I just happened to be present at. So there were these external patient experiences. And then, like most things, right? The outer world is matching something in the inner world. I personally have an ACE score of 3. I certainly also have a diagnosis of complex trauma, which I really wish someone had named when I was a teenager and a young 20-something, instead of being diagnosed with everything from obsessive compulsive disorder to bipolar 2 to all of these things. And I was like, I just don't feel like any of those things are true for me. So for myself, I left college at 19, feeling completely lost and unclear about what I was doing. It was 2002. I was in college in a small liberal arts school outside of Philly. I'd gotten really involved in a lot of peace activism and worked with some of the most miserable people I've ever met. And my adolescent self just couldn't hold the cognitive dissonance of these people who only wanted acclaim for their, social justice actions. And they were so mean to each other.
Wow.
And I just kind of collapsed under the weight of feeling really lost. I couldn't make meaning. I couldn't figure out what made sense. And after leaving college, I started meditating, found a spiritual practice, and really kind of began my own healing journey. But it took years until I was like, oh, what I experienced growing up was complex trauma. I'm not crazy. I'm not broken. I'm not fundamentally a bad person. But I would say so much of my life, do I understand that idea of your core identity being woven with shame? Absolutely. Absolutely. And that's been a journey in and of itself to unwind.
I'm just sitting here thinking what a gift it is that you bring with your patients, with your clients, that you have your own experience and understanding of yourself and what that is and how you can show up for them in that way of compassion. And I just love that. So you left college at 19. What brought you back to the medical field?
So at that point, I sort of tried to commit. This has really been a lifelong journey. But then I was really trying to do things that felt authentic, what actually feels like a way I want to show up in the world instead of all these shoulds that I felt like I was supposed to be doing. And like a lot of people with high levels of attunement survival strategies, that was very confusing. And I really didn't know what anything was. I had no conception of what that meant. But I started, it's funny, now everyone does a yoga teacher training like all the time. But at the time, there were like 2 yoga studios in my little town in Virginia. And so I started practicing yoga and I became a teacher. I went back to college and got a degree in both biology and English because I always loved to read and write. That was just very authentic for me. And biology because I was so fascinated by the mind-body connection. Really, yoga and anatomy. And I started to have all these experiences on my mat of emotions coming up in my body. And I was so disconnected from my own body. I can remember sitting with my first therapist, and God bless her, because I think for months I was like, I don't have emotions. I just don't have them. Other people experience feelings, but I have no feelings. I'm just a very logical person. I mean, just the level of it being cordoned off was so profound. And once I started feeling things in my body, there were all these feelings there. And it was shocking, frankly. I was like, who put these there? I did not put these there. I had no idea they even existed. Yeah. And so that sort of ignited its own process. And actually, I became an osteopathic physician, which I haven't shared. So I'm a DO.
Okay.
And was very intentional about being a DO. For me, it felt like having training that allowed for traditional Western medicine, which is powerful and life-saving and super important to have, as well as a tradition that holds this philosophy of the mind, body, and spirit are triune, and that manual medicine has a role, that we can affect the mind through the body. That just felt very aligned for me. And in moments where I've thought, this is not the right field for me, I'm struggling with all the hierarchy, and there's still so many values in medicine that are not in alignment with my own values by any means, I'm realizing now that it's been a hard fit, even as I have been a good little autonomy survival style girl and been a chief resident and won all the awards for teaching and done all the things and but the system is really complex. One of the other things that I've been involved in doing is teaching about structural competency and teaching about how structures are violent. And we in medicine are part of a structure.
Yeah.
And if we're not taking into account how interfacing with us, the difficulty in getting a prior authorization for treatment, whether that's a medication or imaging, we are part of a system that has created bureaucracy that obfuscates people's ability to connect to care. And clinicians, other than saying, perhaps you need this, we don't know the details of how that care is rendered. That alone creates a certain kind of burnout for caregivers, and for patients is just maddening and hopeless.
Yeah, and I'm just hearing you share a little bit, as someone who has tried to, I've had a lot of health issues.
Yeah.
So I've been in different spaces of care, and I'm just feeling into everything that you're naming, how that can be, it can be traumatic. It can be like the medical trauma of that experience for so many.
Oh, yeah. Perinatal and medical trauma have kind of become two of the things that I'm generally trying to close my practice at this moment. But those are issues that I always see. And I think partially because there's a certain kind of attunement that happens when someone knows they're speaking to someone who intimately understands what it means to be told by a doctor, you don't really have chronic pain. You're fine, particularly for women. I mean, the number of women whom I see with diagnoses in that gray space that medicine likes to ignore, Ehlers-Danlos syndrome, fibromyalgia, chronic fatigue, long COVID may change the game. Now that long COVID is in existence and, frankly, male-bodied people are also complaining of pain everywhere and that deep fatigue, that may offer a little bit more of a window into people with some of these chronic conditions.
How interesting. I hadn't even considered that. Could bring some greater understanding in a way that could promote some societal shifts in that way and in the medical field as well.
Yeah. Well, and that's honestly where, for me, I guess what I'm sharing too biographically is the mind-body connection became really important for me personally and intellectually. I was just fascinated by this. And I think the more you walk that path, the more it became clear to me that complex trauma is often the held mental, emotional, psychospiritual contraction that is leading to, or at least interfacing with all of these physical complaints. And so that intersection between people who have, chronic pain, autoimmunity, migraines, whatever it might be, right? The body is fascinating in the way that it can hold and the systems that people tend to have difficulties with. I love exploring that intersection with patients. And I find that NARM and being able to really have a deeper understanding of complex trauma and its architecture and how it tends to play itself out. And then the clinical skills that NARM gives of being able to just be really curious, right? Just invite all this exploration, which was so unavailable to people in a childhood setting generally. Mm-hmm. And then to keep reflecting back these moments of agency and these shifts, it is magical work.
Yeah.
It feels like birth to me, honestly. Like the way that things will start to shift for people, the energy in the room, the way I feel is truly like attending a birth without all the pressure of, is there going to be a postpartum hemorrhage or a shoulder dystocia, or do you need an emergency C-section, which is very pleasant to not have that pressure, I have to say.
Totally. And I've used that metaphor for myself too, that this work has been like, I'm kind of rebirthing myself as I discover, as I'm peeling the layers, it's like peeling an onion. It's like always there's another layer. And thankfully no hemorrhaging after.
Oh my God. Can you only imagine? No one would be devoted to transforming their trauma if hemorrhaging was at the end of it.
I wonder if that would be like collapse. Would that be collapse? That would be like going into it too quickly and then there's collapse. I don't know what the equivalent would be, but I love that kind of likening the process to like a birth, because it feels like I'm getting to know myself in a different way. And I know I've heard Larry and Brad talk about it, that it's like I'm peeling away the layers that aren't myself, all the ways that I had to compensate. And, so as I peel those away, I'm discovering like a more true. So maybe, I don't know, maybe it's like a second birth or something. I don't know. I'm birthing myself in a more true way of who I am. So anyway, not to talk about myself, but I love that metaphor that you use.
No, but I think it's really true, right? Disidentification, right? So we're inviting, we're exploring, we're trying to, invite this process to unfold within people. It's kind of like supporting physiologic birth, right? It's sort of saying like your body knows how to do this. Agency's already available in you. Mm-hmm. How do we track it? How do we help you notice when you're connected, when you're disconnected? And in doing that, I think so. I really do. When you disidentify, all of this space opens up. And that expansion, I mean, this is what birth is, right?
Yep.
It's contraction, it's expansion. In the tantric philosophy, they'd call that spanda, right? Which is like the pulse of the
Oh.
universe. And spanda is and I'm, again, not a classically trained tantra teacher, but
Mm.
study with them. And I love this principle from that philosophy because things contract, right? We disconnect from ourselves and then we connect a little bit. And then there is that endless pulse. You disidentify and then all your strategies come back up in like a big wave. And just being able to normalize that as this is it. This is the pulse and the rhythm of healing. It doesn't mean that anything wrong is happening. I mean, what else is that but labor?
Yeah. And this is why after I had my first, I went to be trained as a doula because I wanted to watch women in this process. I wanted to see it over and over because every time I witnessed it, it's like I experienced a little bit more of my own, process. So the NARM has just like expanded that even more. I love that.
Oh my gosh. Do you still do doula work?
I don't anymore. I did for years. But that's really what brought me to this work because it felt so aligned with what I was wanting as a doula. I loved working with women and with couples and supporting that process, So anyway, again, not to talk about myself, but I'm just saying that from my experience, that is so valuable, even if it's just 5 seconds of you acknowledging.
Yes.
That's so important.
And this is the training. I mean, increasingly, I have no idea what I want to do with this, but it is so clear to me. I work with a family medicine residency, and I've had several of the residents say, you talk to people really differently. How did you learn how to talk to people? And some of that is just the gift of my own complex trauma. and
brings.
How it forged me as like such a badass attunement kind of person, right? So some of it is that. But I've had to purify that tendency and really learn how you can manage a conversation in a therapeutic way. And this is missing from all kinds of medical education, medical assistants, nurses, certainly physicians. And, medical school really is, and residency, it is an endless fire hose experience. I'm not, and I always think it's important to name, I'm not a psychiatrist. I'm FMOB and addiction medicine. My friends who've studied psychiatry, they do learn psychotherapy. They're mostly learning CBT. They often learn that psychodynamics exists, but they're not getting like psychodynamic tutelage in the way that lineage would even support. And mostly they're doing pharmaceutical management. And that's what our mental health system has primarily decided that psychiatrists do. And particularly in the psychedelic world, there are so many incredible psychiatrists who are merging and integrating like deep transpersonal kind of psychological skills. So always there's different expressions of this. But my point is, no one teaches healthcare workers how to talk to people about what's happening in a way that's validating trauma. But in the last year or two, I've been sneaking NARM in there, but introducing the ideas and introducing the difference between what complex trauma is and how that shows up. I mean, I think about like patients who leave against medical advice, right? And this is getting maybe a little bit more polyvagal, but what is leaving against medical advice other than a flight response in action, right? And to name that to someone, to just be able to say, it seems like this is so overwhelming right now that the only thing that feels safe to you is to leave. Does that feel true? Does that feel like it's real for you? I mean, that alone I found is able to, just this week, I was able to get a patient to stay mostly by saying, yes, it sucks that you're getting induced early. 35 weeks is not when anybody wants to have a baby. And 2, I'm sorry that this did not feel like it was explained to you at the outside hospital where you were before you were transferred to mine. And of course you want to leave. Mm-hmm. That would be a great way to not have to deal with any of this. Yeah. And just that alone and letting her take a bath was enough to, sort of like stabilize and say, okay, great. So we are going to stay and we're going to treat your blood pressures and, pursue care that really is safe for you and baby. But that felt like it was the most important thing to do. In fact, when the physician in training had called me, he said, she's not going to stay. There's no way she's going to stay. And again, by honoring what was alive for her, by honoring how much activation was there, that was able to transmute. And again, that's not, I'm worried I sound self-aggrandizing.
No.
I really mean, this is just about integrating these kinds of skills into clinical practice.
It's a skill.
Yeah.
It's a skill. And you let her take a bath? Is that what you said? That's what it was?
I did. We have remote monitoring, so you can just let her she just wanted to take a bath.
You supported her in taking a bath.
Yeah.
That was what she wanted for herself in that moment.
Yeah, right.
Oh my gosh, how beautiful.
Right. So simple.
So simple. Wow. Yeah, I'm just sitting with that and just really appreciating what you're bringing to the field and appreciating, that you were willing to like navigate systems that really are challenging and hard in terms of like supporting the way that you wanted to practice, but you've like created that for yourself. I just really think that's so wonderful and a beautiful model for anyone listening that is in a similar position or even not necessarily a but there's other fields, right? Like you're naming, like there's
Right.
other fields that like the systems that are set up can be so challenging. And how can we get creative and curious about
Yes.
bringing our work and how we want to practice in whatever that field is and
Right.
doing that in a way that feels aligned.
Yeah. And just creating space for the fact that, in medicine, we've gotten very excited about, the adverse childhood experiences study. And in the state of California, where I practice, there's now reimbursement if you do ACEs screenings for patients who have Medicaid or partnership health plan. But again, we screen for something. Congratulations, you have an ACEs score of 3 or more. We would recommend further services. If you don't actually have further services to refer to, has your screening actually been helpful? Well, it could be helpful if you had a fleet of clinicians and clinics who were really able to see and understand that maybe there's more nuance, maybe there's more individuality and autonomy that you need to provide for that patient. But, a lot of clinicians are very autonomy survival style oriented.
Yeah.
And if they feel like someone is not following their plan or not following the plan that evidence would outline as currently best practice, they shut down or they get angry or they dismiss the patient completely. And I think that's where I see a lot of harm being done. Our inability as clinicians to sit with what a patient may be choosing for themselves and to not think that what we've done is enough by counseling about risks and benefits and documenting that. Like that might be enough. But I think in therapists, it can be one thing, but in a clinician, that impulse to fix can concretize in a way that can be very harmful to both patients and certainly the person who's holding that same sense of this is what I must do and it must look this way as a form of fixing. Because when patients then don't match that, it creates a lot of, again, pain for all involved.
Yeah, I'm really hearing instead of this, how would I say it? It's like instead of the doing to, it's the being with. How can we be with them?
Yes. Yeah.
In a different way. Well, thank you so much for that. I'm really just appreciating what you're bringing to the field and what we're all learning as we listen to your experience. I wondered if there's anything else that you've learned kind of in this journey that you've taken over the last, I don't know how many decades, maybe, how long it's taken you to get to this point, but anything else that you'd like for us to know?
I think the thing that comes to mind is the part of me that resonates with like the archetype of the wounded healer, that there's more possibility for those of us who feel wounded, but who want to be of service. I mean, I think I have felt such pressure my whole life. I can actually remember the moment when Brad was teaching about autonomy survival style. And I just got this image of this big red balloon and it's like it popped. And then for weeks afterwards, I was like, oh my God, I have no idea who I am anymore. I mean, to take away that pressure to be of service, to show up this way, to endlessly, do more of a 90-10 version of living one's life as opposed to a 50-50, you can reconnect to a felt sense of agency and see what that looks like in your life. And I think when we surrender to that more, and there's a sense of trust, there's an authenticity to how your healership shows up, which is really different than thinking that this is my licensure and this is what I must do and this is what practice looks like. I think that there's a creativity to the practice of healing arts of all stripes that certainly in a Western medical model is underexplored and feels really complex for people to navigate because employers say, I'm covering your malpractice and of course your benefits and all these other hooks. But I guess I would just like to really leave people with the idea that as we keep walking our paths, as we keep letting this contraction and this expansion happen in their own rhythm, that what you're left with, and I think you described this in your own journey, is this little authentic you. Mm-hmm. And that can show up in such a different way than you could ever have imagined. So possibility, I think that's the word that's coming up for me.
I love that. possibility. Thank you so much. If there's folks that want to be able to find you and the work that you're doing, you mentioned that you've given talks out in the community, and if there's anyone that's interested in connecting with you, and you said you're in Northern California, is that right?
I'm in Northern California. Yep. I'm in a rural part. I'm in Humboldt County.
Okay.
Yeah. So I have a website, which is where my private practice, that's kind of the best way to access me there. And it is literally my name, carriegriffin.com.
Okay.
And I'm on Instagram, which is managed by my younger millennial, wonderful office manager and psychoeducator, because I am an old millennial
I love it.
who doesn't totally understand. But that's at Dr. Carrie Griffin. And I'm part of a speakers bureau for First Five, which is a California organization which focuses on how to address and heal childhood trauma in the first 5 years of life. And so, if people are interested in speaking, I've spoken a lot as well about how to infuse trauma-informed care in the medical setting as well. I've spoken to some nursing units and medical staff. And
wonderful.
Yeah, if people are interested in exploring that, this feels like one of my deepest loves and passions, is to bring in these waves of how do we work with the trauma that's inherent in our bodies, in our patients' bodies, and in the experiences that happen within the medical system.
Wonderful. Well, thank you so much for sharing that. And we'll be sure to put that in the show notes for anyone that's interested in connecting with you. Well, thank you again, Carrie. This has been lovely. I appreciate you.
Thank you, Emily. Thanks for sharing a little bit of your own birth journey.
Yeah.
Honored to hear it.
Thanks for hearing it.
You're welcome.
Thanks so much for joining us for today's episode. To find more about our guest and their work, check the show notes or visit us at narmtraining.com/transformingtrauma. If you're a licensed mental health practitioner, we invite you to join us for either of these Level 2 NARM therapist trainings beginning later this spring. In this training, you will learn a comprehensive developmental framework and clinical approach. As you are learning and integrating NARM, you will receive individualized support from this team of skilled, passionate, and supportive trainers. For more information about both upcoming trainings, please visit narmtraining.com/level2. That's narmtraining.com/level2. Thanks to Andrea Klunder and the Creative Imposter Studios for producing and editing, to Tori Essex for our album art, and to Brad Kammer for the creation of this podcast. We look forward to building community, connection with you, and changing the world by transforming trauma.